Hi, this is Andy and Alan again, talking about return to healing on a Sunday morning. And we were going to talk the next couple weeks about primary care. We're both primary care doctors. I'm internal medicine, Alan is family practice, and very few other people are. We collectively we have three kids going into medicine, and if you mention to them going into primary care, they just laugh and laugh at you. And that seems to be the general view of it. In fact, Alan, I was driving home listening to a comedian, and he said it was the segment was called primary care, and he said, "I went to my primary care doctor, and I realized anybody could do this because all he does is refer. Oh, you have knee pain? Okay, you go see an orthopedist. Oh, you have a headache? Okay, there's a neurologist I know." And that's like the opposite of what we are, or and what we think robust primary care is. So I mean, this view of it, I don't know. You teach primary care. Is that what keeps people from going into it, or because we know how great it is, we know how important it is.
Right. So, unfortunately, Andy, like in every other profession, there's, hopefully great doctors like we think we are, and we're not being sarcastic in saying it. We have long followings of patients for 35 plus years, each of us, and patients keep coming back to us, and patients do well, and patients like us, and our patients get better. Uh, and we're not the referral kinds of primary care doctors. We've been extensively trained, just like any other physician, of 4 years of college and 4 years of medical school and 3 years of residency training. And we continue to take exams our whole life to maintain our certifications. Many fields don't have to do that. And we're actually the opposite. Yeah, I refer a lot, but a lot might be 10% of my patients, where 90+% of what I do is within my office for my patients. We are the physicians for chronic complex illness, things like hypertension and diabetes and chronic heart and liver diseases and things like that. And most of that does not need to see a specialist. We pride ourselves on continuity. To me, primary care is about continuity, okay, not about referring out to some other doctor. When we refer out, we expect the doctor to come send them back. But what we see a lot is, you send out to a specialist that might not be a regular one you use because of an insurance plan, and they start doing 9 million things to people. So it's the opposite. And I find, most of the young doctors are not referral crazy or referral happy, however we want to call it, that they do believe in the continuity relationship. And, what I always teach is you need to practice to the full scope of your license. You need to do everything you can for that patient, as opposed to sending them all over the world, because by doing it, they're going to get better care. The costs will be lower, but more importantly, they're happier and healthier.
Yeah, I mean, I think that a lot of my colleagues feel like if you have a cardiac problem, you should see a cardiologist, et cetera. But what we bring to the plate is our relationship with our patients, combined with our very global knowledge of age, socioeconomic status, and the entire body. Let's say as an example, so, one of my colleagues sends someone to a cardiologist for congestive heart failure, which is fluid in the lungs, something I am perfectly capable of taking care of. I've probably taken care of more people with that than most of the young cardiologists who are being referred to. And I understand how the medicines for that will impact other aspects of the patient. I also understand how we can't just simply get blood work blindly on people like this, because that there'll be different effects and different ages and different other conditions that affect blood. So it's not just taking the heart and removing it from the patient and looking only at the heart blood work and the heart medicines and everything. I have to say, look, yeah, I get it. You have congestive heart failure, but you also have kidney disease. You also fall a lot. I know that you don't love peeing too much, and we got to take that into consideration. And we have to view the whole patient. And I find that my patients do get much better care under that rubric of care, which is total patient care and listening to them and realizing that everyone's the same. Look, the cardiologist in my town, when they get referred to by a primary care doctor, they'll say, "Oh, you have a little kidney disease." They won't say it's from the medicines they gave, which it is. They'll send them to a kidney doctor. Then the kidney doctor might send them to your urologist. And now we're in this pit of what we know. And there have been studies, lots of studies on this. There's a whole Dartmouth index that talks about this. That when you start doing that, your life expectancy drops. Your burden of sickness and chronic disease increases. Whereas when you stick with the primary care providers, who know you and are willing to not be referral machines, you are going to have a much better outcome. And that's what studies have shown. And Alan, that's what I've seen over and over again.
And that's why the cardiologist doesn't see the whole person. We see the whole person because we know them for years. So, taking care of heart failure, most people would say, oh my God, that's a specialty disease. I mean, there's 5 staple drugs that are used to treat heart disease. You can go on your phone and say, what are the drugs of choice for heart disease? And 5 classes of drugs will come up. And if you send a patient to the cardiologist, they're going to put them on all 5, sometimes at one time.
Yes.
And because they're treating, they're going by an algorithm, they're going by a guideline. And all of a sudden, now you see the patient after they started these other drugs and they walk into their office and their blood pressure is like non existent. It's 60/40. They can't get out of bed. They've fallen, and they're miserable. And then you check their kidney function and it's a mess. And then you have to stop all the medications and go and start one at a time. Like that's how I work things in my practice. Like I don't over medicate. I'm not saying you might not get to those 5 medicines, which do have some evidence,
Mm.
but you're not going to start them all at once and make the patient totally miserable in so many different ways and screw up their labs because they're going to end up not taking any of them as opposed to taking 1 or 2 of the 3 that might be best for them. And the specialist, unfortunately, doesn't see that whole picture. And you're right. They then refer to another doctor, whether it's a kidney doctor, urologist, and the kidney doctor starts Jardians, and the urologist starts Flomax, and then their blood, which makes them pee better, and then their blood pressure drops even more. They get up to go to the bathroom in the middle of the night after taking that, and they pass out and break a hip. So no one's looking at that whole picture of a patient, the whole person care, the continuity care, the relationship based care, and what really matters to the patient, what matters to them about their life and how they feel, and not just, again, it comes back to treating numbers.
It comes back to treating numbers and protocols, and you're right. I mean, I talked to a cardiologist in my town. She's was a researcher at Hopkins forever. She's got this most stellar credentials, but everyone is the protocol to her. Yeah, we even had a little argument about cholesterol medicines, and I said, the protocols you're throwing at me are for people under 50. I'm talking about a 90-year-old here. Well, it doesn't change. And she also says if one medicine's good and another medicine's good and another medicine's good, even though they've never been studied together and never been studied in anyone over 70, let's put them on all 3, like you said. I mean, and they walk out with 6 or 7 medicines. And so we are skeptical of medicines. We are much more focused on lifestyle, where we use medicines, certainly, but we realize that, as Osler said, if you have a problem and you start a medicine, now you have 2 problems. And we do not want to give multiple medicines all at once. There's no rush here. This has probably been going on for a while, and we want to do it the best way possible so the patient can have a life and have no other problems from the treatment. But specialists don't do that because they only see one organ. They cannot see beyond their organ. They cannot see the whole patient. But whereas we do, and I think part of the allure, part of the joy of being a primary care doctor to me is the idea that unlike all these specialists, I could put the whole picture together, that I'm much more critically thinking because I'm not just looking at the heart, I'm looking at everything. I'm also not going to go by any protocols because, to be honest with you, I've never seen a protocol that relates to the patient sitting in front of me. It might give me a sense of things, but not really. It usually throws me in the wrong direction. So I'm not going to do that either. And I'm going to read a lot, and not just go to the American College of Cardiology conference and see what they have to say, because they're biased, and I'm going to read non-biased stuff. So I'm going to be the doctor who gives you, who is it? I always said growing up, Alan, they said, what kind of doctor you want to be? I said, I want to be the doctor where if I run into someone in the store, they say, that's my doctor. And that's kind of what I am. I'm the doctor. And the comedian can make fun of us, but that's not who we are. That's sad example of people in primary care. Usually if a person comes to us, they say, wow, I learned so much today and a lot to think about. And I really appreciate that you really care about me. And that's usually what I hear from most of my patients.
Right. And that's the Flexnerian model of, there is a drug for every number. Okay. And let's just look at the numbers and put the drugs on to affect that number without, again, looking at the total picture. So, we could go cardiac's easy to talk about. You talk about like atrial fibrillation, cardiologists, same thing. They put on 3 or 4 drugs and everyone gets a anticoagulation like Eliquis or Xarelto or Coumadin. Like these, they don't realize that, they're looking at the individual in front of them and it cuts down X% the chance of having a stroke. And people think, well, if I go on these drugs, I'm never going to have a stroke. And people think if I'm not on the drug, like I'm going to have a stroke tomorrow. Like if I don't, the cardiologist said, if you don't start the anticoagulation today, you're going to end up in the hospital with a stroke, like in 3 days. Not looking at, what is the evidence for percent of strokes per year. And, Coumadin or Xarelto decreases it by, 0 point something 5%. But the risk of that patient, which they often don't go into because they don't have the patient walk, they don't see the patient leave the office, they're coming to an exam room, and they don't realize that it's a frail person that might fall getting off the exam table and break a hip or bleed into their head. In my hospital, if you fall on an anticoagulant, you're automatically admitted to the hospital to watch you for a couple of days because you might bleed somewhere at some point.
Yeah, and that is exactly what I've fought with cardiologists about, is that, we have studies showing if you're that frail person you talk about, your risk of getting a stroke is higher on the drug than off the drug. I sent one of these to an expert EP cardiologist. Now, just so you know, an EP cardiologist not only goes to cardiology, but goes to special training after that to deal with heart rhythms. And I sent him this article and I said, listen, you're telling all my patients they got to be on this blood thinner or they're going to get a stroke tomorrow. I said, here's the reality. And he said, oh, I don't agree with that study. I said, what don't you agree with? Have you read the study? He said, I haven't, but given what it says, it's not going to be correct. And I said, well, here's another study. And you know what he did? He hung up on me. This is a guy half my age. He hung up on me. He did not want to deal with me pushing him like that. And this is often what I deal with. You're in a more academic world. I'm in a world where these cardiologists, we have more cardiologists than primary care doctors in my town. And they just constantly find new problems, measure new things, find new problems, do more tests, find new problems, more medicines. Patients say, God, I didn't realize I was that sick. I said, now you are. Because now your whole life has been medicalized. You're anxious all the time, and you're on 20 new drugs, and you're feeling like garbage. And yeah, that's what happens when you don't have good primary care. And honestly, we don't have enough good primary care. People aren't going into it. Um, Most people are going to specialty care, and most doctors now, the vast majority are specialists. It's just more lucrative. And maybe next week we'll talk about why that is. Well, why we're having this problem in primary care. Because, Alan, unless we fix this problem, unless more people go into primary care and we have what I call robust primary care, where primary care physicians are able to do what we do, which is to spend time with patients, speak with them, get long-term relationships, and truly be able to read and understand. Unless we have that, our health system is basically on life support.
Well, our health system is on life support. And,
Yes, it
many
is.
people, unfortunately, for many reasons, just don't realize the benefits of, and there's so much data out there that a continuity relationship with a primary care physician, you live longer, you live better, you're hospitalized less, you go to the ER less times, you're on less medications, you have less adverse reactions to things, your spending is less. And you brought up, I forgot to go to the Dartmouth Atlas and, the Dartmouth information out there. Like they have a tremendous amount of data out there that shows like the more treatment you get, the worse you do. The more doctors and more specialists you see, the worse you do because you end up in the hospital more, you end up in the ICU more. You're less satisfied with your care and your outcomes are worse. In fact, people who live in like Idaho and Montana live longer than the people in New York City and Los Angeles and Washington, D.C. And a lot of it has nothing to do with the lifestyle. It has to do with the overutilization of medical care that they get. And the data is really showing that. But people are like, they don't want to look in the mirror. People in these more rural states, they eat better, they exercise more, they get out more, they socialize more with their friends and family, and they're not relying on the doctor for everything. Because once they start relying on the doctor, they end up hospitalized for something stupid, and then they get a hospital-acquired infection or an adverse reaction. We talk many times, it's upwards of the third leading killer in our country might be accidents in the hospital, and nobody kind of gets this. Like they think it's a safe place. I tell people all the time, the hospital is the place to go if you're dying or you need a surgery or something like that. But you don't, go in for a little tune-up because you could do the tune-up at home by your primary care provider without having excessive things done to you. So it's just the knowledge of people is not out there, and in fact, more affluent people end up getting worse health care because it's the more affluent people that think, well, it's my heart, I got to go to the cardiologist, and it's my stomach, I got to go. And that starts that referral cascade that we both know of. They don't know enough about the condition except their heart. So I couldn't find anything in your heart, go see the gastroenterologist. And then the gastroenterologist says, well, the cardiologist says it's not your heart and it's not GI. So, maybe you need to see an orthopedic doctor or something like that. And then, 6 doctors along the line, it's like someone must say, well, we can't find anything wrong with you. Maybe you're just stressed out and, you need to have a therapist or something like that that will help you with your condition, or get out and take a walk and enjoy life a little bit and stop going to doctors so much.
Yeah, the last patient who went down that cascade, they were on memory medicine given to them by the neurologist, and that caused all the symptoms. And not a single specialist actually even considered that, because God knows medicines aren't bad to the specialists. Medicines are the panacea to everything. So specialists caused the problem, and that led to multiple more specialists and tests, and literally tens of thousands of dollars of spending, anxiety producing, and all I had to do is stop the medicine. That was it, which
Yeah.
was a useless medicine anyway. So
And we both know very well the workup for memory loss or early dementia or age-related memory loss. Half the people just have what's called pseudo dementia. They're depressed with their life because they have a miserable life, so they're not happy. Like we know the tests that need to be done. Every once in a while, they'll get a patient saying, I got to go see a memory specialist. Okay, and they end up going. Like we can't stop people, so with most of insurances now, and they want to go, they go. And like 100% of the time they come back on 2 useless drugs, like every time. And I'm like, what are you taking this for? Well, they said maybe it would do something. I said, yeah, probably make you sick. That's what it's going to do.
yeah, you have a problem, now you have 2 problems, the old adage. So I guess so. Yeah, so maybe let's next week talk about, if primary care is this important, and it is, why the heck does it seem to be on life support, and why is no one going into it, and why is no one respecting it, and why don't healthcare reformers talk about it as the solution to our problem? So we'll talk a little about that next week, and
Well,
hopefully get some answers
Well, we
to
kind of
some.
know the solution. The solution always comes back to money. The medical industrial complex of big pharma, big hospital, device makers, specialty organizations. They like the status quo because there are a lot of people making a lot of money. And, we won't go to the fact that primary care is of the lowest paid of specialties. And, I guess one of the least glamorous and least respected, but the one that has the best effect on our healthcare system and on individual people's health.
Yep. And we will talk all about it next week.
All right. Have a great week. Take care.
Okay. Take care.